Hey guys, my name is Ibreez. I currently work as an internal medicine trainee in Daraford Hospital. And I know you guys have already heard a lot from Ibrahim about how you can go ahead and get your CREST form signed off as an international medical graduate in a non-training post. But I wanted to touch on again a little bit more about the SLEs, your Supervised Learning Events, and how you can basically ensure you do as many as you can in this role before you transition into a training post so that you have all the things ticked off in your CREST application. All right, so as he said already, we've got 3 things that we need to discuss. 1 are your DOPS, then 2, your Mini-CEXs, and 3, your CBDs. So with your DOPS, let's talk about DOPS for a little bit. Most of the DOPS that I got signed off, I basically got them signed off when I was on call, doing stuff like, my acute care, acute medicine kind of stuff, like, when there were admissions, or if I had to review patients on nights, or if there was anything to that nature. I'd got a couple of them done even in A&E, but I feel like for DOPS specifically, when there are a lot of procedures to be done, A&E is not the setting to do a lot of procedures that are really relevant to the stuff that we would need in our CREST. But when you do stuff like acute take, or when you do stuff like admissions for acute medicine, you have a lot of opportunities when you see a patient after they've come from A&E to do things like NG tube insertions or lumbar punctures. It's just about you being proactive. Even if necessarily you've not seen that patient yourself, if you hear it in the wind that this is something that needs doing, you can even go ask that person who is actively seeing the patient, hey, listen, would it be all right if I, did this? It's all up to you about asking, because you can't just sit there and hope and pray that a patient with meningitis comes to the door, or, a patient who needs an NG comes to the door, because it's not always going to be like that. You might have a whole week when you're on call where you're only seeing patients who've come in with a fall or something very simple to approach that wouldn't necessarily need all of those, investigations. So, like I said, it's really, really a good idea to be super proactive, keep an eye out, keep an ear out. If possible, you can make a WhatsApp group with your other non-trainees, or even with the trainees, and everyone kind of just pool in there and say, hey, this is what I need doing. If anyone hears about anything like this, let me know. Call me, text me, page me. I even used to tell my reg, or the occasional, because there were different regs on different days for whenever there would be takes, I would just be like, here's my number. Please let me know if this kind of thing happens or that kind of thing happens, because I want to do them. So with that, I was able in my 1 year as a non-trainee to do quite a few things. I learned how to do fascial blocks. I did acidic caps. I did lumbar punctures. I did NG insertions. And then, of course, all the other basic stuff that you do on the day-to-day, like cannula insertions, ABGs, kind of sort of helping out with a relocation. Mainly, I was just a counterweight. But it is something at least that you can experience, and you're showing that you are willing and you are active. All right? So beyond DOPS then, let's talk about for Mini-CEXs. Mini-CEXs are things that really, you could, I guess, almost easily pull off in any scenario, in any setting. It could be at A&E on the ward, or if you're, just being on call for take. Because really it's just about examining a patient with the consultant or the reg being right there, seeing what you're doing, and then you explaining your findings back to them. So, as a junior doctor in an A&E setting, you need to review your patients before that patient goes off anywhere anyway with a reg or consultant. So this is a prime opportunity for you to be like, Dr. So-and-so, I was just listening to that patient's chest and it sounded like it had some crackles and maybe there was decreased air entry. And then you go and you're like, let me show you what I heard and everything. You go and do the examination, all the steps required depending on whatever, clinical findings you've gotten that patient, what are the other symptoms that they have. And then you present that, like, listen, this is what I heard, this is what I found. And then the consultant will be like, yes, okay, you've done this Mini-CEX related to this patient. All right, Mini-CEXs can be done on the ward just as easily as well, because the patient, it changes day to day. If a patient came in initially with pneumonia and then they're getting better, but then you're thinking something else might be going on, there could be a reason for you then to do a further examination, and then there you are, Mini-CEX done. From that, then, what we've got left are the CBDs, your case-based discussions, which again could really be done anywhere, except I find that you might have a hard time doing it in A&E, just because A&E is really pressed for time as is. I mean, you've got a 4-hour window, and to do a case-based discussion, even though you are in the board rounds just generally talking about the patient, this is what happened, this is what I'm doing, this is what's going to get done, I wouldn't necessarily consider that to be a formula for a perfect CBD, because there really is an element that needs to be there for discussion about why you're doing what you're doing. So on calls, if you're doing takes, if you're post-taking with a consultant, is like the perfect place to get them signed off, because essentially when you're post-taking, that is the whole element. You've gone and you've seen a patient, you've understood what's already been done for them, you've put together your plan, what investigations you want done for that patient, and you said, well, this is what I provisionally think is wrong with the patient, this is what I want to do, and this is where I think the patient should go to get the best care available. So doing it in a post-take situation or even on the ward is probably the best for you. But like I said before, the real most important thing about getting these SLEs done is being proactive. No one is going to hand you these cases. No one is going to tell you, hey, look, just come here and we'll get it done. It's up to you to be that person to look out for these things, to keep, aware of what's happening around you. I know a lot of us as IMGs might be initially reluctant to start in a post that requires us to be on call, because you want to get a feel for things and just kind of, do the basic rota 9 to 5, no on calls. So if you do that, and that's fine, because, if it works for you, that's what works for you. Look in the ward for things that you can do, but I would suggest as soon as you start feeling comfortable to try and do some on-call posts as a non-trainee rather than being pushed into doing them as a trainee, where you would have less flexibility. Okay, guys, I really hope that makes sense to you, and let's get on to our next topic about how to be a clinical teacher.